So today we have the great opportunity to hear from Dr. Asrani, who will speak to us about tumor lysis syndrome in DLBCL. We chose this topic because though it is a rare um, phenomenon, it is a potentially life-threatening complication for cancer patients. With that, I'll go ahead and quickly introduce Dr. Asrani, and then we'll turn the time over to him. Dr. Asrani is an assistant professor of medicine for the Division of Hematology and Medical Oncology at the Icahn School of Medicine at Mount Sinai. As part of the graduate medical education process, he interviews, selects, and trains fellows in oncology. Dr. Asrani is the wellness chair overseeing the wellness of the fellows. He also sees and treats patients through the Lymphoma and CLL program at Tisch Cancer Institute and is also actively involved in research and clinical trials in lymphoma. And I will go ahead and stop sharing and turn the time over to you. Thank you, Dr. Asrani.
Thank you, Cynthia, for that introduction. Very lovely, and thank you for having me here. And I'm really excited for everyone to be able to give you this talk on tumor lysis syndrome. I don't have any financial disclosures or anything with pharma as of now, so I'm going to put that up there. And essentially, today's topic is a really important one in terms of, like we were saying, it's a life-threatening emergency that can occur really in many cancers, but especially in diffuse large B-cell lymphoma. And it's something that usually happens earlier on in therapy before therapy is initiated or right after therapy is initiated. So essentially, I think I just lost my slide. Sorry. Let me bring it back up. Okay. So essentially, it's an oncologic emergency where the internals of the tumor cells are released into the bloodstream from either spontaneous tumor death or from our treatments. And just to go into that, I'm going to kind of reiterate some things in different ways with different pictures to try and make it as clear as possible. But essentially, when we have these new cancer cells in lymphoma, if the tumor cells start to overgrow their own blood supply, they can actually die off in the process. And this term, when they die off and break apart, is called lysis. Similarly, when we add, treatments like chemotherapy, radiotherapy, certain pills that we use to treat cancer, we can often kill the cancer cells too quickly almost, and they can release all their contents into the blood. And these contents can be toxic and cause issues that can be life-threatening. Some of the things that can be released are the DNA from the cancer cells, which can further break down into uric acid, which I'll go over a little bit later, and also the internals of all cells in the body, but including the cancer cells, contain phosphorus, calcium, potassium, certain electrolytes that can get off balance when circulating in the bloodstream. So this can result in a host of problems, and I'll go over that in a second as well. The symptoms of tumor lysis syndrome can be quite generalized. It can involve, basically anything that is caused by electrolyte disturbances mainly. This includes, getting cramps, getting nausea, having changes in the bowels like diarrhea. It can result in low energy or fatigue, especially when the calcium levels change. This can affect how our muscles work and how our brain works. You can get certain cardiac arrhythmias or irregular heartbeats, basically, that can occur from potassium levels rising very quickly in the blood, and that can be very life-threatening and requires urgent attention. Additionally, in the process of both preventing and treating this syndrome, we often can see patients develop an increase in the fluid in their body, and that we can term as heart failure, as well as electrolyte issues that can result in seizures, especially if the calcium levels go very low. And you can also have some issues with kidney stone formation, which I'll go over when we talk about uric acid a little bit. And these kidney crystals can result in bloody urine, abdominal pain, and as well as swelling and kidney failure. So this is a little more detail on that. It's more just for your reference, but I'll try and go through it just as a visual. So, when the tumor cells break down, they release the DNA components. The DNA is broken down through several series of steps in our body, into something called uric acid. You may have heard of uric acid in other forms potentially, because uric acid also is the main culprit in gout disease, and is often treated with a treatment called allopurinol for that, which we also do use in tumor lysis syndrome. And the other sort of issues that could come about, like we were mentioning, when we release a large amount of potassium into the bloodstream, it can result in cardiac arrhythmias. And when there's a large release of phosphorus into the bloodstream, it can actually bind up with things that are in the bloodstream, like calcium, and can form calcium stones, or it can also lower the calcium level, which can result in seizures or muscle issues. And then there are a whole host of other toxins that are really inside the cell that shouldn't be outside. And that includes things like lactic acid and other metabolites that are meant to be processed inside of those cells. Now, I was mentioning we're going to go over uric acid briefly, so I just wanted to show you a visual of this. So uric acid is not very soluble in the urine. And when our body has high levels of uric acid, the uric acid actually can combine and form crystals. And those crystals can, usually form inside of the kidney where the urine is being formed, and can cause, your kidney damage, and as well as essentially blood in the urine and pain. So we often are targeting correction of uric acid when we are trying to treat tumor lysis syndrome. The way your doctor usually will diagnose it is through a series of blood tests, really basic labs that we would check on any patient usually. This includes the electrolytes in the blood. So if the electrolytes like potassium or phosphorus are too high, or if the calcium is low, this would give us a hint. And then uric acid levels will rise up to a significant amount, and we can measure that in the blood as well. And then most importantly, we want to measure how the organs are doing in the situation, and we measure the kidney function. So we measure these labs, the serum creatinine and the blood urea nitrogen, BUN. So this gives us an idea of what is going on in the body during this time. And then the other tests that can be helpful are lactate dehydrogenase. Like we were mentioning, the cancer cells can release lactate in the process of breaking down. So if the level goes very high suddenly, it tends to imply that there's lysis or breakdown of tumor cells. And then the urine analysis also can be helpful, because sometimes we can see the uric acid crystals in the urine themselves. This is a little detailed, but just to kind of put this here for your reference, but we define this syndrome based on the occurrence of these labs with certain values. So usually if uric acid is over 8, or if it increases more than 25% after starting treatment, for example, we would consider that tumor lysis syndrome. And then we would use the electrolytes as well to guide us there, and say that if the potassium is also high above 6, or the phosphorus is high above 4.5 in adults, or if the calcium drops to less than 7. These all can be hints that this is going on. And then the severity of tumor lysis syndrome is really determined by the end clinical results of what happens from it. So if the kidney function declines, meaning that the urine output goes down, the person's not able to pee as much, then usually their blood creatinine level will go up, and that can correlate with how much of their kidney function is down. The typical normal level of creatinine is somewhere around 1. So if we see it rise up more than 1.5, then we start to say that there is some kidney injury going on from the syndrome. And then we also, if we see other sequelae, such as cardiac arrhythmia, like we were mentioning from the potassium, that would also make it more severe, or if there are seizures from the same as well. There are certain risk factors that put patients at risk for tumor lysis syndrome. Obviously, when there is a large amount of tumor, this can be a big risk factor, because there's a lot more of the tumor tissue in the body. So usually a tumor that's more than 10 centimeters is at high risk. Not so much in diffuse large B-cell lymphoma, but in certain other lymphomas like CLL, if the white blood cell count is very high, like above 50,000, then that could also be a risk factor. And then, the aggressiveness of the tumor can determine it, especially for a tumor that is spontaneously breaking down or causing tumor lysis syndrome before even getting treatment started. And diffuse large B-cell lymphoma is one of the cancers that is considered highly aggressive and often grows very quickly and is therefore at very high risk for this syndrome. We use this lactate dehydrogenase that I was mentioning earlier as a surrogate marker of the internal contents of the cell. So if there's a lot of that release in the blood, that would be a sign that there's already a large tumor burden. And then how much kidney function the person has prior to starting therapy also matters, because all of these electrolytes and the uric acid are regulated well by the kidney on a normal basis. So if somebody doesn't have a well-functioning kidney, it puts them at further risk for damage from this syndrome. And then we tend to tell people to avoid certain medications that can put the kidney at risk for injury. Some of those include things like non-steroidal anti-inflammatory drugs like ibuprofen. And if someone is not drinking enough water, that also, dehydration can result in kidney damage as well. And then this is sort of an interesting factor, is that, the more effective a cancer therapy is for a cancer, the more risky it is for tumor lysis syndrome. So, perhaps in the past we didn't have as effective therapies, we didn't see as much, but sometimes some of our newer therapies are so effective that they kill the cancer so quickly that we have to be even more vigilant about this tumor lysis syndrome. So I'd say we're probably seeing this more, not less than we used to, but we do try to prevent it in all of our patients. And then in diffuse large B-cell lymphoma specifically, since we're kind of gearing this talk towards that, some of the treatments that you might have heard or you see, either yourself or your family member going through could include things like R-CHOP chemotherapy or R-EPOCH chemotherapy. These have, essentially a lot of potency in lymphoma and therefore could break down the tumor very quickly. So we often will have to put someone on this on, some allopurinol, for example, before they start therapy to prevent the uric acid from building up. And we'll have to give them instructions to hydrate well and maybe even give them some IV fluids before therapy. And then some of the newer drugs, like this new drug called obinutuzumab, is an antibody drug that is so potent that it actually does result in a lot of tumor breakdown. And we do see, even with this antibody drug, large amounts of tumor lysis syndrome. And then some of the other therapies that are kind of new and developing are also cellular therapies or CAR T therapy, which would be used more in somebody who has relapsed diffuse large B-cell lymphoma. Those patients also can have a very potent response to therapy and could result in breakdown. And then lastly, radiation therapy, which we don't use as much as we used to, but in certain circumstances, we do utilize it, and it is very effective against lymphoma, just that we try to avoid the toxic, component of radiation on the body or the bystander effect. So the best ways to prevent, tumor lysis syndrome or is really to have adequate hydration before treatment. So we encourage patients to drink a lot of water while they're going through therapy, before starting therapy, and we often do have to use IV fluids if somebody is not able to keep up with it, especially because their appetite is not like it used to be when they're sick. And then the other medicine that I keep mentioning is allopurinol, which is the one that's originally formulated for gout. This medicine, we usually will give this 300 milligram dose, and it usually will help to prevent our body from making uric acid from that DNA that's released from the cancer cells. So it can be very helpful as a preventative measure. And then in terms of treatment, it's a little bit more of the same, but depends on how severe the situation is. So, if somebody already has some tumor lysis syndrome going on, the allopurinol can prevent them from making more uric acid, but they can't really break down the uric acid that's already in the system. So, the only real way to get rid of uric acid that's already there is to either flush it out through a well-working kidney. So, if somebody's kidney is working good, we can give them a lot of fluids in the IV, but then we also usually have to give them medicines to help make them pee more, to help make sure that their blood volume and their body volume doesn't keep going up from getting so much fluids. So it's one of the only situations in medicine where we'll give somebody fluids and diuretics to help them pee off the fluid. And then that basically cycles them, cycles the uric acid out of their system, as well as some of the electrolytes that are high, like potassium and phosphorus. Similarly, there is the option for giving this medicine called rasburicase, which actually does digest uric acid that's currently in the body. So this is one of the only ways we can lower the uric acid, especially if the kidney is not doing a good job of getting it out of your body and it's already too damaged to pee out the excess. Then we would give you this, and this would help to lower that risk and get rid of all the currently available uric acid in your blood. And it's a very effective therapy, which very quickly lowers the levels of uric acid. And then some of the other things we might do in the process are use binders for electrolytes. So if the potassium levels are very high, we do have certain drugs now that can bind to the potassium, or we can give you something that will make you go to the bathroom more and basically put it out in your stool. And then we also have binders for phosphorus. One of them is called sevelamer. So this can be used as a good therapy to make the phosphorus level go down from and be prevented from being a problem. And then, if the calcium levels drop too much, we often have to supplement it carefully, but knowing that the calcium and phosphorus interact together. So the doctor has to be very careful about how they do it and, essentially has to make sure the phosphorus is first being treated, but we usually have to replace the calcium if it's very low to prevent, again, some of those muscle spasms, seizures, and, essentially that electrolyte related disturbance. And then the last case is where if we don't have the option where the kidney is just not doing its job, we may need a little course of temporary dialysis. And throughout my career, I've had to do this in the hospital several times. And it's usually just a temporary measure until we can get all of this cleared out. And then once the levels of these toxins are out of the system, the kidney usually is able to recover nicely, and we are able to get back to a well-working kidney situation. So it's very rare for someone to have permanent kidney damage from tumor lysis syndrome, especially if it's identified very quickly. And then, like what I was mentioning, when you have a treatment with a lot of fluids, one of the risks is that the fluid can build up in the body, because if the kidney is not doing its job, then, the fluid that you're putting in with the IV, it might just accumulate in the person, and then we call that heart failure. And it could even go into their lungs. So to prevent that, we'll usually try to use those, drugs called diuretics that will help to pee off the excess fluid. And if that doesn't work, then our last ditch effort would be, again, the dialysis temporarily. So because the electrolytes are so off, another thing to keep in mind is that your doctor will have to monitor the vital signs very closely, the labs very closely for changes in these numbers. And then they also will keep a very close eye on how much the person is peeing, because if they stop peeing suddenly, then they're at very high risk for things worsening. And then depending on how serious the situation is, we have sometimes had to put someone temporarily in the ICU for monitoring of these electrolytes and to treat the syndrome. And then usually after a few days, they're able to come back, to the regular floors, and they'll be able to go home. And then if we were mentioning the enzyme rasburicase, this is just what a vial of it looks like, essentially an IV medicine that we use to help break down uric acid. And then again, just to kind of revisualize some of this, when this is a little word on uric acid and how we treat that. Essentially, when the cancer cells break down, they release all this DNA into the blood. DNA goes through a lot of recycling in the body naturally and is broken down in the bloodstream. Some of the enzymes that do that will eventually convert it into uric acid, which was, again, that culprit that causes kidney stones, crystals, and is really one of the main culprits in tumor lysis syndrome. So what we can do is, the allopurinol will act on one of these enzymes called xanthine oxidase over here. And basically, allopurinol will stop the body from making it into uric acid in the first place, and it will make it into a more soluble form that's able to be peed out. And then the other option is if we're, past that point and there's already uric acid sitting in the bloodstream, we use this drug, rasburicase, which will convert the uric acid into a more soluble form called allantoin, which is about 10 to 20 times easier to pee out. So your body will be able to handle it much better. So essentially, to summarize everything I kind of just said, basically tumor lysis syndrome is a very serious oncologic emergency that does occur, in a lot of our diffuse large B cell patients, and we have to be very vigilant and watching for it and preventing it, and essentially looking out for the blood work and the symptoms, which could be these non-specific things like nausea and vomiting, diarrhea, some fatigue. Very rarely, arrhythmias or cardiac issues, seizures. That would be in a situation that's a lot more severe. And then often we'll establish the diagnosis by checking that routine blood work, which gives us the electrolytes, the uric acid levels, the lactate, which is found inside the cells. And then we'll use, the best, treatments we can for the time. If the person is in a situation where they can still prevent development of tumor lysis syndrome, then we would rather them hydrate and take allopurinol to prevent building up uric acid. If they're already in the situation where there is some tumor lysis syndrome, then we'll have to increase the amount of hydration, possibly give diuretics, correct the electrolytes that are off using those binders that we mentioned, maybe even temporary dialysis if that's the situation. But overall, I would say the prognosis is very good, and it's really excellent for tumor lysis syndrome, and most cases can be resolved very quickly through either prevention, early detection, and treatment. So it's a very it's a problem that's serious, but it's easily dealt with when we're looking out for it. And that kind of concludes what I had to present to you guys, and I can go through some questions.
Okay, perfect. Thank you so much. That was a lot of great information in a really succinct amount of time, so thank you. So it is now time for the discussion part of today's webinar. If you have any questions about tumor lysis syndrome or anything that Dr. Asrani spoke on today, now's your chance to ask questions. As a reminder, you can ask a question or make a comment by typing it in the chat box, or if you prefer to ask your question verbally, go ahead and click on the raise hand icon. And once you're called upon, you can unmute yourself and ask your question. But while we wait for questions, there were a few things that obviously I learned today during today's webinar, and it made me think about how, well, oftentimes in other disease processes, like comorbidities and different things increase your risk. It's going to make things more difficult to treat and
Yes.
potentially, yeah. So is that found in tumor lysis syndrome as well?
Definitely. So, whatever situation the patient brings into it is going to, lead to different results of how tumor lysis syndrome can present and how serious it can be. So I'd say the sort of biggest couple of comorbidities to list off in that regard would be kidney dysfunction being number one. So if somebody has some baseline kidney issues, either from diabetes or from high blood pressure, and their kidneys aren't at baseline very good, or they're taking some medicines already to treat themselves for something else, like they have pain and they take a lot of ibuprofen or naproxen or one of these medicines, then their kidneys just don't work that well. And then that combined with, this very aggressive tumor and treatments that work very quickly can form this perfect storm and make it a lot more likely that they end up in the situation they do. So that would be the worst, probably comorbid thing that you could have coming into it. The other thing to point out would be someone who already has a cardiac history or has something called heart failure, because they aren't very good at managing a lot of fluid in their body. And often the biggest treatment we do is trying to flush the body of all these toxins, because really we're utilizing the kidneys to do their job and get rid of all of this excess tumor related breakdown stuff. So if the heart isn't good, then that can result in fluid accumulating in the lungs, and that can be a very serious situation where someone might end up in the ICU very easily because of that morbid condition. Yeah.
Okay, perfect. And I guess in that same vein, is there anything with those comorbidities, if somebody already has a comorbidity, is there anything that they could do to decrease their risk of tumor lysis syndrome, or is it just hope?
Yeah, I mean, I think the probably number one, two, and three of prevention is hydration. So somebody has to maintain very good hydration status, even if your kidneys are baseline not good. If you're well hydrated, they're more likely to work well. If you don't have any fluid in your system, you really can't. They can't do anything. The kidneys are an organ that depend intensely on having a lot of blood volume. So if you basically don't have that and you're dehydrated, the first thing our body does is shut off the kidneys to save the blood for all other essential organs, essentially. So that would be probably the biggest thing to do is to hydrate well. And then allopurinol, we basically give to all of our diffuse large B-cell patients in the beginning of treatment. So it's something that's routine. So any doctor seeing a diffuse large B-cell patient would put them on allopurinol right before starting treatment, or as soon as they meet the patient almost, because it's just something very easy to take and will help prevent the buildup of this uric acid in the first place. So it definitely can help. Yeah. Other than that, I mean, it's hard to correct heart failure, for example, before getting cancer and things like that. It's hard to correct that, but definitely, we try our best to manage everything, the whole situation coming into it. Yeah.
Perfect. That makes sense. I know that kidneys that are busy are happy kidneys. Those
Yeah,
kind of
for
like,
sure.
yeah, nice
Yeah,
be
you always want to
hydrated.
be drinking water and peeing it out all the time. That's kind of our natural order. If we're not drinking enough water and we stop peeing, even as healthy people, that's already not a good thing. That means that we're not doing our job. So yeah.
Right. Absolutely. All right. We did get a couple questions. So I've got one from Dan. It says, thanks for the excellent presentation. I had fever visits to the hospital after my first two R-CHOP treatments, 5 days each, and the attending physician explained tumor lysis syndrome to me, and I was on close monitoring. I had a huge tumor load, but was lucky and had no complications. I was measuring input and output for the nurses, doctors, just in case. I guess that's more of a comment about
Yes, I could
treatment.
kind of take that comment though and make another comment on it, which is, well, first off, it's really good news that you made it through without any complications. That is amazing, and that is, really good situation that you got through such a aggressive tumor and made it through the beginning of treatment. And I think there was a question right before that kind of is related, so I'll put those two together. So, can this occur in early stages of disease? And essentially, that's kind of the point I want to make with Dan's comment, is that usually this occurs in the beginning of disease. So for somebody who has not started treatment yet, they could spontaneously develop it if their tumor is very large. It could be the first presentation of their lymphoma to the hospital in some situations, rarely, but they can come in with kidney issues, their labs are off, they get admitted to the hospital, then they find out that they have lymphoma. That's also one way I've diagnosed people when I'm treating them in the hospital. Often that risk goes down as we treat because the tumor burden keeps going down, and we've already started some of these preventative things. So the risk goes down with time. And I often will take patients off of allopurinol just to take one pill off of their burden after about 2 cycles of treatment. So, like you were saying, the monitoring went down after 2 cycles. That's about when the risk kind of drops down, and that essentially is the timeline too. Two cycles where it's sort of the magic window where things are usually better. We start to see a lowering of the lactate dehydrogenase, which is the marker of the tumor burden, and we start to say maybe we can stop this medicine.
Perfect. Perfect. We've got a question about lab tests that are essential to monitoring tumor lysis. I know you
Yeah,
went over this a
so
little bit.
lab tests that are essential is, a lot of them are done on routine labs, which is great. So we can pick them up even on somebody who we aren't looking for this for, but essentially the electrolytes. So, we're looking for what's their potassium doing, what's the calcium doing, what's the phosphorus doing. And then basically, if those levels for the potassium and phosphorus are high, then, that is a big hint that there's something being released. And generally in a lymphoma patient, that would be tumor lysis syndrome. And then the calcium drops because calcium has this complex interaction with phosphorus. So as we release a lot of phosphorus in the blood, our body, both hormonally and physically, the combination of that drops the calcium level. So we see a low calcium. That all gives us hints that we're seeing the same syndrome. And then the uric acid, of course, that we mentioned, the lactate dehydrogenase, being things that are directly released, and the uric acid being made in our body, basically.
Perfect. I had a follow-up question about how fast do those levels usually rise? Is it patient dependent or it,
Yeah, it can vary, but I'd say that generally very quickly. So there are some patients who have such aggressive disease that even when we start them on steroids, which is a treatment used in part of the curing of lymphoma and also as a symptom management of the lymphoma, both the cells can die so quickly even just from the steroids that the labs could immediately go up. And then especially if it's right after you receive a therapy, it could be the same day, a few hours later. So generally, when I'm seeing someone who's very aggressive, who's in the hospital, I will start by monitoring their tumor lysis labs every 6 to 8 hours. And then as we see those levels stabilizing, I'll start to peel back the number of blood sticks and say, okay, now we can start seeing this every day or every, twice a day. So we kind of peel back as we see that.
That's perfect. I like the way you've described it today because it does make a lot of sense. More, the higher the tumor burden, the more risk there is for developing tumor lysis
Correct.
syndrome. So as it goes down, you're going to worry about it maybe a little bit less.
Correct. Absolutely. Yeah. So it's all a consequence of that early part of the disease when we don't have it under control. There's a lot of disease. We haven't yet started therapy, maybe, and we just started it, and it's like this is the highest risk moment for that, tumor lysis syndrome. Yeah.
Perfect. And we just had one other comment from Dan. I was glad to hear this. He said he had 8 R-CHOP treatments for DLBCL, and luckily he's had a complete response. So that is
That's
very
excellent.
encouraging. Yeah,
Yeah, luckily R-CHOP chemo isn't terrible. We have been trying to improve on it, but there have been a lot of clinical trials over time that have yet to really show huge improvements on other things. So generally, the first treatment most patients will see is R-CHOP, with about 65% on average, like complete remission rate, which eventually hopefully leads to cure in that patient. And that's why, even though it's a very aggressive tumor, it's not the worst cancer in terms of outcomes. So, and that's just with the first treatment. We often do have a lot of new therapies down the line now. So we're really able to get the disease under control, even if it is not fully cured with the R-CHOP. But
very
I'm very
good.
happy to hear that for Dan.
Yeah, absolutely. We always love to celebrate those good
Absolutely.
bits of news. Um, and I guess that so this kind of came up in my mind as we were just talking about that last little bit about um, with our newer regimens where we're seeing, things turn around really quickly. Um, are you seeing more instances of tumor lysis syndrome because
Yeah. So
everything's
I'd
being
say
under
the
control so fast?
incidence is going up because, it's kind of a catch-22. We want really effective cancer therapies, but usually the really effective ones work quicker than these older therapies did. So R-CHOP works fairly quickly, in people who it's going to work on. So that part is kind of similar, but in the relapse setting, I'd say this happening is happening more than we used to see it, because we used to not have as effective therapies after somebody has relapsed. Now, some of the newer therapies are so quickly, acting, and then the person's disease burden might be high again after they have a relapse, so they might be at risk again. So they definitely can see it. I mentioned briefly there was a drug that we use called obinutuzumab. This is very similar to the rituximab in R-CHOP, but it's a much more potent drug. So it binds a lot more strongly. So it actually can result in tumor lysis syndrome just on its own. And we often use it before we give some of the newer therapies to try and debulk the cancer to prevent other complications besides tumor lysis syndrome. There are some other newer side effects that are happening in some of the new drugs that like cellular therapy based drugs. So we use that, but we have tumor lysis syndrome. So we have to use all of our preventative skills and monitoring to make sure we don't end up in that situation.
Very
Yeah,
good. Very good. Okay, I think that's all the questions we've got for today. I just want to thank you again, Dr. Asrani, for your
for
time
sure.
and for sharing this information with us. It's always good to be well informed and know some different things that can happen going in. So thank you.
Absolutely. Thank you for having me.
I'm gonna go ahead and share my screen again. Go, and we'll finish up for today. Here we go. All right. Before we go, I wanted to highlight the Twin Machine feature in HealthTree Care Hub. The Twin Machine features harness the power of genetic data in an unprecedented way. The Twin Machine can identify individuals with remarkably similar genetic profiles to you, effectively connecting you anonymously to other users who share genetic traits as if they were your biological twin. This can help you see what someone else's disease is similar to you is doing, who may be ahead of you in their disease journey. The more patients that sign up for HealthTree Cure Hub and connect their medical records, the more opportunities there will be for you to find your twin machine. On the screen, I have the link to sign up for HealthTree Cure Hub, along with the email address of our amazing patient navigators who are available to help you create an account and connect your records. I'll also include this information about how to enroll in HealthTree Cure Hub in our follow-up email, so look out for that. As a reminder, we'd appreciate you taking the 2 to 3 minutes to fill out a brief survey about your experience today. Zoom will prompt you to take it as soon as you leave this event, and you can submit topic ideas through the survey. We have additional DLBCL and SL events in the works for the coming months. In November, we have a member of the Community Access, Resiliency, and Education Bureau who will speak to our group about health literacy to improve communication with you and your care team. So be on the lookout for more details and the opportunity to register soon. But in the meanwhile, on Monday, September 30th, to round out Blood Cancer Awareness Month, we'll be hosting an Innovation for Blood Cancers webinar, where we will hear from 4 experts in different blood cancer fields to talk about the past, present, and future of blood cancer care. And then on October 1st, we have a financial webinar about upcoming changes to Medicare for 2025. The link to sign up for any of those events is found at the bottom of the slide and will be sent out in the follow-up email within 48 hours after the event's completion. I'd like to again thank our sponsors, Regeneron and Bristol Myers Squibb. And finally, I just wanted to say thank you for helping us build our DLBCL community. I've added my email to this slide. Please don't hesitate to reach out if you have any questions about HealthTree or any of our programs. I appreciate all of you and hope you have a great rest of your day, and see you at another webinar soon. Thank you.